Joining. We're just going to give a few seconds for everybody here to kind of funnel into the Zoom room. A big crowd tonight.
Short week, big start to the week. How are you, Carolyn?
I'm terrific. How are you, Jessica?
Good, good. Always great to see you.
You too. I know, long time no see. Just been optometry's meeting and can't get enough of you.
In 3 dimensions, this is great. Zoom is fabulous, but
Yeah.
there's something about 3 dimensions that it's always great.
Well, thank you everyone for joining us here on this lovely Monday evening. And tonight's lecture is entitled Revealing Glaucoma's Depths, Advancements in Pathophysiology Understanding by Dr. Jessica Steen. I'm your moderator, Dr. Carolyn Major. And we want to give a special shout out and thank you to AbbVie for exhibiting and sponsoring this event. Just a few reminders and housekeeping items before we get started. So for each hour of CE units, attendees must be online for a minimum of 50 minutes. And for COPE certificate, you need to fill out the survey link in the chat that will be at the end of the lecture. The survey is also going to pop up as soon as the webinar ends. So you need to make sure you fill out that survey at the very end of the lecture to get COPE credit. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We're also going to display a QR code at the very end of the event. So if you have the OE tracker app on your phone, you can snap that QR code. You make sure you can't just use your regular camera. It has to be the OE tracker app to capture that QR code. CE certificates are going to be emailed within 4 weeks. And please ask questions because we're going to have a live Q&A here at the end of the lecture. So make sure you're asking questions throughout the lecture. You can use the little Q&A icon on the floating panel down at the bottom if you're using your laptop to attend. But if you're joining us from your phone here this evening, you can also ask questions. So there's a Q&A little box at the top as well as those 3 dots down at the bottom. So funnel some good questions in. And without further ado, it's great pleasure to introduce our speaker, Dr. Jessica Steen. So Dr. Steen is an associate professor at Nova Southeastern University College of Optometry, where she serves as director of the glaucoma service and as an attending optometric physician at the college's Eye Care Institute. Dr. Steen teaches the courses in glaucoma and ocular pharmacology at NSU. Dr. Steen also serves the university sorry. Dr. Steen also serves as the primary care with emphasis in ocular disease residency coordinator. She graduated from the University of Waterloo School of Optometry and Vision Science and completed her residency in primary care with emphasis in ocular disease at Nova Southeastern University. And Dr. Steen's main clinical interests include glaucoma, retinal disease, neuro-ophthalmic disease with an emphasis in medical and surgical management. And Dr. Steen's research interests are centered on artificial intelligence applications in the management of glaucoma. She's a fellow of the American Academy of Optometry, a diplomate in the American Board of Optometry, member of the Optometric Glaucoma Society, and the Association for Research in Vision and Ophthalmology, and is past president of the Palm Beach County Optometric Association. So without further ado, I'd love to have you take it away here, Dr. Steen.
Thank you very much, Carolyn. And one more reminder, Wednesday night, Dr. Jesselyn Quint has another COPE accredited CE opportunity through Woo U4U. It's wonderful to be with you. The team at Woo are just a pleasure to work with. And it's incredible to start this series on glaucoma management and to start it in maybe a different way and a different mode of thinking for us as clinicians. We rarely back up and think about the foundations to what we do clinically. So through this series, you are going to have incredible opportunities to hear in depth about management, surgical, laser, medication, detecting progression, determining disease presence with advanced technology. And all of that comes together based in the true understanding of pathophysiology of glaucoma and this foundational understanding of what we see clinically. Now, I think this is more important than ever. When we're thinking about the advanced tools that we have access to and the tools that we know are under development, how are we as clinicians different? How are we offering something more? What are our clinical insights rather than detection or determination of red versus green versus yellow on an OCT printout? Or automated detection of change on a visual field or OCT. This depth, this understanding of the optic nerve is one of the things, one of the many things that makes us different as clinicians and is truly going to be so important, not just now, but moving forward as we take care of patients with glaucoma. My financial disclosures are here. Of course, the important piece is that all relevant relationships have been carefully mitigated. When we really back up and think about where our suspicion of glaucoma comes from in any patient, it's really not just the family history. It's really not just the intraocular pressure. It really comes down to, from a clinical glaucoma perspective, the optic disc appearance. And when we're thinking about optic disc evaluation, what we're really talking about is assessment of the health of the neuroretinal rim, which, as we know, is best assessed behind the oculars at the slit lamp using a magnified view. Now, something that we don't often think about is that the health of the neuroretinal rim, what we're actually interested in glaucoma, is not at all assessed by a cup to disc ratio. Yes, I do document a vertical and horizontal cup to disc ratio in my record, but that's the last piece of assessment. Where my focus is looking for focal neuroretinal rim loss or focal damage to that tissue that is indicative of a glaucomatous process. Now, as we think about more challenging optic nerves to assess, we think about how our clinical view lines up with what is happening anatomically. Now, for those obliquely inserted optic discs that we see, this is an OCT image in cross section, and we see that overall tilt. This is, again, a tilted or obliquely inserted optic disc that gives us that slightly elevated nasal area, depressed temporal parapapillary region, often with parapapillary atrophy. These can sometimes be challenging optic nerves to assess, especially when found in highly myopic eyes, when there is significant scleral stretch. Now, if we look at that basic, again, model, when there's scleral stretch, which happens with axial elongation, the lamina cribrosa stretches and strains along with it. This is the important reason why our highly myopic individuals are at a greater risk of developing disease. It's these connections that we make as clinicians when we back up and understand the anatomy that really helps us to best evaluate what we see clinically. Now, for these obliquely inserted optic nerves, why is it that we get these large areas of parapapillary atrophy? This is our, square peg, round hole type of analogy. The scleral canal is a different shape than the optic nerve that is passing through it. This allows for that imperfect fit and that gap that's ultimately created. Now, here's just another variation of optic disc appearance. This is a 51-year-old with primary open-angle glaucoma. He takes Combigan twice a day in each eye and Rocklatan once a day before bed in each eye. And if we look at that pigmentation that we see fairly symmetrically, right and left eye, we see this area of parapapillary atrophy far, let's look at the left eye, far temporally, that lighter area with a very dark area of parapapillary atrophy. And what's this gray boundary? This is actually folding over of the RPE. These are some of, the really nuanced details that as we're studying the optic nerve clinically, we're looking for these features. I think something neat that we'll see in a moment, we look at each optic nerve, and certainly this patient has glaucomatous optic neuropathy, but the remaining neuroretinal rim tissue, especially superior, looks fairly well intact, more in the right certainly than the left, and not always does the function match the severity of what we might expect versus the structure. Clinically, this looks like very advanced disease. Now, just because we spend a lot of time looking at optic nerves, I came across another patient that is a totally different 58-year-old man who has this very similar folding over pattern. This is not something that we would really think about in a comprehensive exam, But when we are truly studying the optic nerve, we're truly looking for any subtle changes to the neuroretinal rim, and you can't help but notice this folding over this grayish area bounded within the optic nerve. I think that's another very important piece as we're assessing the disc, is to truly understand where the outer optic disc margin is, so that then we're able to assess where the neuroretinal rim is present. All right, let's go back to this gentleman. Advanced glaucomatous optic neuropathy clinically. By OCT, we can again put in these different features and evaluate the nerve and the retinal nerve fiber layer in different ways. We find even in cross-section, this focal area in the right and left eye, primarily inferior temporal, where even in cross-section, if we break down and flatten out from a circle into a flat line of the retinal nerve fiber layer, this focal area of retinal nerve fiber layer loss that corresponds to the area of damage clinically. I almost see this as a check for myself. Is the area of damage that I see clinically, does that make sense with the retinal nerve fiber layer detection? This patient, again, does have advanced damage with generalized depression, but maybe these fields are less severe than what you may expect. Again, another highly myopic individual. Why else do we look at the optic nerve every single visit? As we're watching patients every 3 or every 4 months who have a glaucoma diagnosis, every single visit, I'm undilated, usually 3 times a year if they're being seen every 3 months. I dilate patients once a year unless clinical indication requires more frequent dilation. But why am I looking at the nerve undilated or attempting to do so at every single visit? Not to measure a cup to disc ratio, not to detect if there's been a change in neuroretinal rim health from 3 months prior. We are not going to be able to detect that clinically. Why we look at the nerve every single visit is for the presence of a disc hemorrhage, because that is something that very well may change your management, may change your testing frequency. Sometimes these disc hemorrhages can be very subtle. You see, I'm a proponent, even in an age that we rely, unfortunately or fortunately, on significant technology to help us take care of patients. The importance of a fundus photograph, this is a digital photograph, is so important. If you find what may look like a small disc hemorrhage clinically, and you say, shoot, is that a vessel? Is that a subtle disc hemorrhage? In the examination room, it's not uncommon for me to pull up an old photograph, take a look at that patient clinically, refer back to the photograph in the exam room and determine, aha, new disc hemorrhage, or that's a little vascular anomaly that was present at the last visit as well. No disc hemorrhage. This is why we look at the optic nerve. This will not be detected by OCT. We can look at the variation and variability in optic discs. Large optic nerves certainly have large optic cups. This is a young woman in her late 20s with a disc area of more than 4 millimeters squared. When we say, what's a big optic nerve? Megalopapilla, generally described as over 2.5 millimeters squared. I don't measure that at the slit lamp. I do rely on the OCT to provide the disc area measurement. So if we were going based on optic cup alone, the vertical, or let's even say the average CD ratio is 0.83 in the left. That's concerning on its own. When you take a careful look at the neuroretinal rim health, maybe inferior temporal in this patient's right eye, the neuroretinal rim looks slightly thinner. When we assess the retinal nerve fiber layer thickness with OCT, we see how beautiful and robust the retinal nerve fiber layer is in this patient with very large optic discs. In the left eye, this is a little tuft of glial tissue that's remaining. Now, in our highly myopic individuals, this distinct 360-degree parapapillary atrophy, once again, we have retina that doesn't come all the way up to the outer margin of the optic disc with significant axial expansion, with axial elongation. Again, we don't have tissues that are butted up right to one another. This is something interesting, especially in high myopes. What one of the thoughts is as to why this parapapillary atrophy may be associated, this parapapillary, sometimes called halo, may be associated with glaucoma development and progression, is that if we go back to basic natural anatomy, the inner limiting membrane, the neurosensory retina, Brooks membrane in the RPE should be right up against the scleral canal and the optic nerve. What we have here is absence of the neurosensory retina and the RPE. And part of Brooks membrane, what we're looking straight through to is the choroid and choriocapillaris. We've lost our natural physiologic boundary that protects the retinal nerve fiber layer, the axons of retinal ganglion cells that pass superficially. So the thought is when there is loss of that natural barrier, those axons may be at greater likelihood of experiencing oxidative stress, driving glaucomatous damage. I know that's high level. I know that's digging in, but that's our understanding of physiology and the connection with what we see and manage clinically. So I think sometimes we don't give ourselves enough credit. Classically, and I'll say this is even one of the reasons where I became interested in glaucoma, was the concept that maybe we don't know that much about why people develop glaucoma, why some people progress, why others don't. It always seems that when we talk about glaucoma diagnosis, management, and risk factors, that we have more questions than answers. But if we truly do back up, what we find is that we actually know maybe more about glaucoma than sometimes we like to give ourselves credit for. When it comes down to it, we know the address of glaucoma. We know where it lives. From a posterior segment perspective, that is truly primary site at the level of the lamina cribrosa. In the anterior segment, glaucoma is not an aqueous inflow disease. The body doesn't create too much aqueous. Where's the problem that drives elevated intraocular pressure in primary open-angle glaucoma? A reduction in aqueous outflow through what pathway? Primarily through the trabecular system. That's the region. We're particularly interested in the juxtacanalicular tissue and that inner wall of Schlemm's canal. Why this is so important is that this becomes, in 2025, a target for medical therapy, for surgical therapy, whether that's MIGS or, again, for laser therapy like SLT. Understanding the underlying damage and stressors that drive reduction in aqueous outflow, increased intraocular pressure, allows us to evaluate, design, and utilize therapies. This is so important for our surgical colleagues, but also so important for us as optometrists as we're thinking about medication selection. We no longer just think about lowering the pressure. Genuinely in clinic, we think about how are we doing that? Now, certainly I do still use, of course, we need to use aqueous suppressants in many cases with disease, but they're not my first choice. And truly, in 2025, they are no longer my second choice. I focus on aqueous outflow, prostaglandin analogs through the uveoscleral system, and thinking about Rho kinase inhibition and the impact of nitric oxide donating molecules on the trabecular outflow system. Now, very briefly, because this is deep for a Monday night, one of the pathways by which aqueous leaves the eye are through these giant vacuoles. I think the most important piece here is to think about glaucoma as exaggerated changes related to aging. We all have reduction in trabecular outflow over time with natural age. That is exacerbated to become pathologic in glaucoma. Now, at the back of the eye, when there is compression or shearing stress of the laminar sheets, we have to think about what passes through those pores. Those are the axons. When there is stress to the support system surrounding each axon, that means that the axons are sheared and stressed, leading to blockage of axoplasmic flow and axonal transport, leading to overall ganglion cell death, this backward bowing of the optic nerve that, of course, we see clinically. As glaucoma progresses, there is this deepening of the optic cup. This happens because of loss of ganglion cells. So if we really look at where we are, what is our goal in glaucoma management, and are we there yet? Our goal is true disease modifying therapy. poke a couple of pieces that might be curious. I don't think we are truly there with disease modifying therapy. Again, we think about how we lower intraocular pressure in glaucoma management. Lowering IOP is the way we think about managing glaucoma. But if we focus a little bit more in depth on a couple of treatments, there is some highly researched laboratory data that may suggest that some disease modification is possible. Bottom line, when we think about developing a new therapy in any disease state, it is developed based on the understanding of how the disease develops, either this interruption of pathophysiology, or with what we'll see is enhancement of natural physiology. So let's look at this woman. She's 57. Now, she came in because her son was diagnosed with glaucoma and is managed by a colleague. She has type 2 diabetes and a history of cervical cancer and breast cancer, both in remission. She's 20/20 with intraocular pressures of 20 and 25 millimeters mercury with a very thin cornea. Now, again, it starts with the optic disc assessment. Where I want to draw your attention to is the superior neuroretinal rim in the right, and even more so in the left eye. Her visual fields, there is an arcuate scotoma in the right eye. And, if you call that a nasal step in the left eye, it doesn't look like it's quite passing the vertical midline. Very reasonable. This patient's function matches her structure. And I haven't shown you the OCT. We can get that information based on our careful clinical assessment. So you've diagnosed glaucoma. Yes, we've put a gonioscopy lens on the eye in order to understand, is this primary open angle glaucoma? Is this angle closure disease? Or is there a secondary cause? Once we've diagnosed disease, our focus shifts to determination of progression. And truly, we're pretty good at reducing the incidence of glaucoma-related blindness. Certainly, individuals still do go blind due to disease. Unfortunately, in many, not all, but in many cases, this is related to delayed diagnosis or challenges in maintaining care in a clinical environment or good adherence to therapy, whether that is medication, whether that is appropriate follow-up after a surgical procedure. And the challenge in glaucoma is that this is not a short-term condition. This disease state requires management and adherence throughout a patient's life. We talk about diagnosing disease earlier. So that 45-year-old that you've just diagnosed with primary open-angle glaucoma, how many years do they hopefully have to live? 55, 60 years to go? That is 60 years of managing a disease process. I think that's also important to reflect on. Yes, we talk about SLT as a first-line therapy, which it is a very reasonable therapy and should be offered, in my opinion, as a first-line therapy. That doesn't mean everyone is going to choose SLT or it must be done first line. But we do think about all of the treatments a patient may need in their lifetime, and how do we ensure that we are buying time for potentially the next MIGS procedure or the next surgical procedure or another SLT. So again, as we're managing patients, it is important not to overwhelm care or overtreat early on. Being aggressive is appropriate, but do keep in mind the long haul in disease. And that's actually something that I tell every newly diagnosed primary open-angle glaucoma patient. I talk about how we're going to manage the disease, what the next steps are, and I remind them that this is not, just a 1 to 2 year period. I remind the patient that we're going to get to know each other really quite well. And this is something that I am going to keep on top of and manage with you, not for you, with you for the rest of your life, which may be 50, 60, 65 years. Understanding that it is a long process sometimes can be difficult for patients early on, but something truly so important to ensure that they understand that, again, this is not a short-term disease, but we're in it for the long haul. One of the significant game changers in reducing incidence of glaucoma-related blindness, truly, were prostaglandin analogs. We know that the risk of blindness due to angle closure disease far outweighs that of primary open-angle glaucoma. Also important to ensure that we're diagnosing their patients accurately on that first day. Now, once a patient is determined to be stable, how frequently do we see the patient? Why do we see patients every 3 to 4 months despite having that patient appear to be stable in the office? Because they will progress at some point. We just don't know when that's going to be. So we set a follow-up schedule that if they progress the next day from the patients that we have all seen today, if they start progressing tomorrow, and I see them back in 3 months, it won't be so long that there will be a significant functional change. It's not a negative way of thinking. It truly is a realistic and appropriate clinical way of thinking. How frequently do we perform testing? That depends on the patient. Ideally, we want to match our testing frequency to that patient's disease state to best be able to detect change in that particular patient. That is not going to be the same in all of our cases. Generally, pachymetry we're going to perform once. I do prefer performing pachymetry utilizing a light-based technology like OCT. What I find for patients who have had previous, let's say 2010 to 2015 or so, or earlier to 2015 or so, central corneal thickness measurement with ultrasonography, when I repeat the pachymetry utilizing a light-based technology, I generally find that the ultrasound pachymetry has overestimated the central corneal thickness. Now, sometimes this is a couple of microns. That is not clinically significant, but sometimes that could be 20 to, I've seen as much as 40 microns. That is clinically meaningful. That can impact treatment. Gonioscopy is necessary for diagnosis and repeated every generally 1 to 2 years. I'll reperform gonioscopy every 2 years or on any visit when there is an unexplained intraocular pressure increase. Now, OCT of the anterior chamber, it's not a replacement for gonio, but does have some possible advantages or ways that it can be complementary. Truly, I think to help us to determine if the angle is open or closed. Here's a patient with, what do we have? This concave iris approach in pigmentary glaucoma. We're looking at a flat iris approach versus this is plateau iris configuration. Don't mind those calipers. They are not drawn in the correct place. There is appositional touch on the temporal aspect. We can't see the same features clinically as we can potentially identify on OCT of the anterior segment. Let's look at this woman. She's 73. This is a recent patient who is new to me. Her daughter is a nurse and had brought the patient in for a better understanding. The daughter is an excellent historian. Her mom was diagnosed with primary open-angle glaucoma outside of the United States in her 40s. She has been treated with topical medications. She has not had cataract surgery. She uses 2 bottles. One's a small bottle that she puts in once a day before bed. That's a prostaglandin analog. And the other one is a bigger bottle. And when I asked what cap color, it's dark blue. So that's a fixed dose combination, whether that is brimonidine timolol or that is dorzolamide timolol. It's one of the two. Her daughter says no matter what she does, her intraocular pressure is always 30 to 40-ish. I measure her pressure is 42 and 28. What's our first thought for somebody on 3 medications? What's going on with the angle? 73-year-old who has cataract. This is not primary open-angle glaucoma. This is a woman in angle closure. This is, again, real significant risk of glaucoma-related blindness, important to diagnose. This changes the management. Here's the documentation of gonioscopy, and here's her OCT of the anterior segment. Not in every quadrant, but in the right eye. So in the right eye, we see nasal and temporal, that there is some appositional touch. In the left eye, this is temporal, more appositional touch. It looks like there's a little sliver that's open in the left eye. This changes our management. This is not a medical case. This patient needs surgery. Now, how frequently do we perform visual field testing? We know in clinical practice, really not frequently enough. This is where new tools and technologies to shorter testing time make testing easier on clinicians and patients in order to get the good quality information that truly we do still need. OCT frequency has been described, and I think the most important piece is the work by Dr. Bradley and his team. Based on our understanding of linear regression, basic statistics. How many fields or how many scans or how many OCTs do we need to detect change? Ultimately, if you cluster testing, a fewer number of images, scans, or fields are required to detect change. What the conclusion was of this particular group recently was that multiple scans or measurements or both should be taken on the same visit when possible, even at the expense of longer intervals between visits for the purpose of detecting change as quickly as possible. This is not typically practical in a clinical environment. If I ask my patients to do 2 fields on each eye on every visit, I mean, they hate fields already. I have to sweet talk them into performing fields, even sometimes once a year. I don't know how many patients I would have. We think about tying up machines. We think about billing practices. There are true practical considerations, but from purely statistically ability to detect change, clustering is more advantageous than separating our tests, for example, 1 year apart. All right. Now, we know that glaucoma realistically is a syndromic condition. We've got multiple features at play that is somehow related to intraocular pressure, although many individuals with primary open-angle glaucoma do not have statistically elevated intraocular pressure. IOP is certainly still the most important risk factor for disease development and disease progression overall, but the challenge is that pressure measurement is not a valid screening test. There is no IOP level by which we can determine statistical abnormality related to glaucoma or statistical normality. Just because the intraocular pressure is statistically normal doesn't mean the person doesn't have disease. And just because they have ocular hypertension doesn't mean that that person is going to develop or already has glaucoma. So when we talk about intraocular pressure measurement, we take it out of the equation at the time of diagnosis. We bring it back in when we're judging the effect of our treatment. So if that's the case, where does this, 10 or 11 to 21 millimeter range come from? You see, I appreciate historical context. Speaking again, I know this is a large audience and this is a very niche approach, but new season of the Gilded Age, I appreciate the historical context. In this landmark Hollows and Graham publication from the earlier mid 1960s, this is where this data comes from. The intraocular pressure was measured in 1,873 white male left eyes without glaucoma. The normative curve is what we see, the average intraocular pressure between 15 and 16, 2 standard deviations on either side. We get about 11 to 21 millimeters mercury. This is where that normal range, when our patients ask us, what's a normal range in pressure? Sir, your eye pressure today is 17. Is that good? What is normal? This is truly the basis of where that comes from. We have to ensure that our patients are reflected in any population by which we're comparing them to. And, this is a group of white men from Wales in the 1960s. I do not have any Welsh patients. I have some patients from the United Kingdom, but none that would have qualified, would have met the inclusion criteria for this study. Our risk factors for glaucoma development continue to be elucidated. And I think what drives this home to me is understanding that each one of these risk factors that we know and understand are underlined in some way by genetics. This is our next frontier in not just glaucoma management, but truly all optometry, disease management, ophthalmology. There are at least 296 loci that have been identified. And in primary open-angle glaucoma, we talk about complex genetics, meaning that if you have one particular marker or mutation, you are not going to develop primary open-angle glaucoma, but that each anomalous or genetic combination conveys a small amount of risk that when together may contribute to disease development, may contribute to specifically important biological pathways, or drive something like elevated intraocular pressure. There is a currently available genetic risk score service available in the United States. I have no financial interest in this, but I share with you to investigate further on your own. It is commercially available. The name of the tool called SiteScore by Psionics Bio is available. Truly, this is a risk score. Think about it as a thermometer, low versus medium versus high risk. What we do with that information clinically is, again, up to us as clinicians. Understanding this background allows us to truly get where we target with therapeutics. This is something that our surgical colleagues have done for years in glaucoma management. Think about the MIGS space. Think about when a surgical colleague chooses a specific MIGS device or process. It is truly based on how the device itself increases, usually, aqueous outflow. Is that through the suprachoroidal pathway, which we now have something back once again on the market? Is that through the trabecular system? And if so, where? Are we dilating Schlemm's canal? Are we bypassing the trabecular tissue? What is the mechanism by which that treatment or procedure or device works? That's our thinking as optometrists now in management of glaucoma and lowering intraocular pressure as well. Now, very briefly, just to share some of the controversies and our changes in thinking that I think are still in progress over time. We know genetics certainly plays a significant role. I'm going to talk briefly on two potentially controversial topics in their risk evaluation in glaucoma. GLP-1 receptor agonists maybe are protective for in reducing the risk of development of disease through a mechanism of the thought of reduction in inflammation and therefore glial cell activation. We are still very early in this. Maybe in other disease states, GLP-1 receptor agonists may have a role, including in AMD. So what about the risk of non-arteritic ischemic optic neuropathy? It's now been almost exactly 1 year since this monumental publication was released, and we all started talking about this, the potential increase of NAION. Now, one good news piece for our glaucoma patients rarely, if ever, develop non-arteritic ischemic optic neuropathy. Because who develops NAION? What do those nerves look like? Those are crowded optic discs at risk. Those are not our glaucoma patients, which, if there's one piece of good news for our glaucoma patients and, for example, semaglutide or other GLP-1 receptor agonist treatment, I am certainly not concerned about risk of NAION in my glaucoma patients based on their structural anatomy. Now, this correlation or connection or potential drive between NAION and semaglutide, other publications, much larger publications, have called into question any potential actual connection. If we talk about calcium channel blockers, 2023, these have gone through the ringer of initially being thought of as being protective for glaucoma development. But in 2023, a particular fairly well-performed study, again, UK Biobank, we're talking large data sets, it was determined that individuals taking particular calcium channel blockers had a higher odds ratio of developing or having, I should say not developing, of having glaucoma, which was not dependent on IOP. Another more recent publication, again, this is all recent in the last 2 years, in particular, a specific calcium channel blocker may have an impact or may have been tied to an impact of perceived change or reduction in visual field progression. So what do we do with this information? We don't hang our hat on it. We take it into consideration. I truly do not sway a patient away from a calcium channel blocker if that's what their managing physician feels that is best. Maybe in certain circumstances of advancing, not advanced, but advancing normal tensive disease, I may think about these features in greater detail. Let's touch just briefly, because you will have wonderful conversations about medications. Let's look at innovation across the spectrum. 1893, okay, pilocarpine was about 1877. Physostigmine was 1873, but we still use pilocarpine. I still have couple of patients on Pilo through 2018, which was the last time that we had an FDA approval that led to a commercially available treatment. We think about the options that exist from prostaglandin analogs to carbonic anhydrase inhibitors, alpha-2 adrenergic agonists, beta blockers, rho kinase inhibitors, and pilocarpine. Prostaglandin analogs, we know, primarily increase outflow via the uveoscleral pathway, but something that we don't talk about often is that there actually is a small impact, not significant, but a small impact on the conventional outflow system. New prostaglandin analogs like latanoprostene bunod release nitric oxide to also increase trabecular outflow by relaxing trabecular beams. Preservative-free latanoprost, a preservative-gentle latanoprost, which is still not back on the market. We're still waiting for that one. Nitric oxide may have a role as it relaxes smooth muscle. It increases the space between trabecular beams, but what about neuroprotection? There isn't good quality data in patients with glaucoma. Our colleagues in Canada developed and published this work in 2022 that found that latanoprostene bunod, this nitric oxide donating prostaglandin analog, increased blood flow volume and oxygen saturation versus latanoprost in individuals without glaucoma. This is challenging to study. Is there something there? Not, again, that we can hang our hat on, or not a reason why we may prescribe latanoprostene bunod. We think about it from the uveoscleral pathway and the trabecular meshwork pathway. Now, rho kinase inhibitors are an interesting group of molecules. What we know in glaucoma is that the trabecular meshwork is stiffer in patients with glaucoma versus those healthy individuals. And part of this stiffness is related to the formation of what are called cross-linked actin networks. We know that rho kinase inhibitors relax or expand or impact these actin structures. We also know that steroids, topical steroids, increase clan formation. That drives an increased resistance to aqueous outflow and can increase intraocular pressure. We all know steroids increase or can increase intraocular pressure. This is one of the mechanisms by which they can do so. Rho kinase inhibitors, we have notarcetal alone and in combination with latanoprost, both dosed once daily in the evening. They cause redness. This is something that, again, based on the mechanism of action, they cause mild vasodilation. That's what we're looking at the conjunctiva. This does not cause significant watering, changes that are bothersome or itching or tearing, but the eyes certainly in certain patients can be red. So what do we need in glaucoma management? My perspective on this is something that lowers intraocular pressure overnight better. Prostaglandin analogs do lower IOP overnight, but not as well as during the day. We want better or improved IOP lowering at night. Neuroprotection strategies. Well, we have one in particular that is moving through clinical trials worldwide. That is nicotinamide, generally on its own, initially studied as a phase 2 trial in combination with pyruvate. Nicotinamide is a vitamin B derivative. This is an over-the-counter supplement that is widely available for purchase. Now, again, there is this early phase 2 trial that was performed in individuals with glaucoma had demonstrated a slowing in visual field change versus the comparator group. This led to, again, a worldwide almost drive or push for multiple trials for an answer as to whether or not oral supplementation of nicotinamide could be considered as an adjunct. This is not a solo therapy. This is in a consideration in addition to topical or surgical IOP lowering strategies, but something that your patients may ask you about, something that may be considered. There are considerations for significant adverse effect. There is early work on reforming or restabilizing the blood-retinal barrier as a neuroprotective strategy, and there is a phase a phase 1 clinical trial underway in California related to topical insulin in patients with glaucoma. Now, here's the most recent update related to nicotinamide for glaucoma neuroprotection. Again, more than 300 patients were dosed across trials around the world. At this point, 2 developed acute, significant drug-induced liver injury, which can lead to liver failure. One patient was 73 with normal liver function. This was reversible. One patient was 69 who was part of one of the Singapore trials, and she was very thin, BMI of 15. The overall study protocols were changed for very careful liver function testing through the trial, and there is the recommendation that we do not use the dosage up to 3 grams in clinical trials in a real world setting if this is something that your patients are interested in or curious about or doing on their own, as this is an over-the-counter vitamin. Sustained release options, we have the bimatoprost implant on label for a one-time in someone's life treatment, and the travoprost titanium implant, different as it is surgically implanted, meaning the patient needs to make a trip to the OR. Again, this can be removed and replaced. Now, to touch on SLT, we know that SLT targets melanin, and it has, I will say, a lesser tissue destructive response and wound healing response versus ALT. We've all seen these photographs, these electron micrographs. On the left, ALT, that crater created, mechanical contraction of the trabecular meshwork, increasing trabecular outflow, versus on the right, that is not perfect trabecular meshwork. There is some structural damage. It is just much less than in ALT. What's that target we all look for as you are training or you are now performing SLT? Champagne bubbles. What is that? Explosions at a microscopic level. This is tissue damage. This again ultimately drives macrophage recruitment, trabecular meshwork proliferation. So because of this change, this is not new 10 years ago, some discussion or question as to whether SLT has some features of disease modification. Now, we are well familiar with the LIGHT trial, but what is new is the COAST trial, with an estimated completion date 2 years still away. Now, the COAST design, what the purpose is to understand if annual low energy SLT is reasonable in the treatment or realistically considered with a similar effect to standard energy SLT as needed. So if we use a lower energy of SLT, reduce those explosions below the threshold for those micro explosions, just to stimulate the tissue, with once yearly treatment, is that ultimately more efficacious or non-inferior, would be a better way clinically to think about this, versus standard energy SLT repeated if and when that patient's treatment eventually declines, if they are a responder to begin with, which is anywhere from about 3 to 5 years after treatment. All patients receive standard SLT first and are randomized after a year to receive either that half energy SLT every 12 months, or they receive standard SLT as the investigator determines to be necessary. Something interesting, there was already a change to the trial design to what we're looking at here. Initially, there were patients who started with low energy SLT, but what was determined is at the 12-month mark, they did not have non-inferiority versus standard energy SLT. So the trial was adjusted so that everybody starts with standard SLT and then patients are randomized. Now, there are many patients who unfortunately still progress to requiring filtration procedures. We know that even the patients in our office often require escalations in therapy. 30% of patients over a 4-year period require 2 treatment modifications. And, unfortunately, there is still glaucoma-related blindness as you watch a patient over time for longer periods. We have to think about the adverse effects of topical therapies, of surgical procedures, and do keep in mind the dry eye treatment for this particular patient who had undergone a trabeculectomy in each eye. Now, from a MIGS perspective, very briefly, we know 2 eye stents are better than 1 and 3 are better than 2. It is challenging for us to truly interpret and apply many of the clinical trials that have evaluated MIGS procedures. What you'll find is that some name success as reduction in pressure, or maybe the patient was able to get off 2 bottles of medication. Both of those things are clinically important, but it's hard to compare head to head. My biggest advice for co-managing your glaucoma patients with consideration of MIGS at the time of cataract surgery is to be clear and direct. Here's an 80-year-old who has primary open-angle glaucoma. Her peak untreated pressure is in the low 20s, and over the last 12 years, she's been on almost everything. She's currently doing well on latanoprost, but it's time for cataract surgery. She has glaucomatous optic neuropathy in both eyes, and overall, her fields have been relatively stable. So, what are this patient's goals? What is important to communicate with the cataract surgeon? Truly, in our case, what we would love is to maintain her current intraocular pressure with the ability to remove that prostaglandin analog. I want to reduce her medication load, keep the pressure at that 17-ish level. It's working for her. And in her case, she is only interested in what will be covered by Medicare. Those are the considerations for the surgeon. So as we put this all together, this is really about how this background data allows us to impact and guide clinical decision making. So let's take a very quick look at a couple of cases here, Carolyn, and then we'll talk about some of the good questions that have come in. This patient was actually back in my office today. She has a history of lung cancer and metastatic colorectal cancer, thin corneas, low peak untreated pressure, and very mild disease. Does this patient need treatment? We think about her as a whole. We think about her long-term treatment, not just from an ocular perspective, from a systemic perspective. A 59-year-old who is taking labetalol for hypertension. Now, we've got some artifact and error, but overall, the retinal nerve fibrillary and ganglion cell complex looks really quite good, but she's got a disc hemorrhage. Are disc hemorrhages ischemic stress? In my opinion, they are most likely to be mechanical stress associated with glaucoma. Now, in this patient's case, the labetalol may be a component related to reduction in ocular perfusion pressure, not so much mechanical. In her case, this very well may be related to perfusion. Now, when should patients take their antihypertensives? I think the summary by the American Heart Association describes it best. They should be taken at the time of day that is, 1, convenient, 2, optimizes adherence, and 3, minimizes undesirable effects. Is that morning or is that evening? Again, there may be special circumstances, but it is about the long-term success in treatment. Now, if we look at one last case, if we look at this woman, her retinal nerve fibrillary in the left eye concerns all of us. If we look superior temporal in the ganglion cell complex, there's also this little area of missing data. Is this missing data? Is this reduction? Is this loss? Look at this missing data that we find when we look really carefully. So what do we do before we get too excited? We repeat the image. Well, that makes us feel a lot better. Bottom line, we know more about glaucoma pathophysiology than I truly believe that we give ourselves credit for sometimes. Take the time you need to establish a diagnosis and when making treatment decisions, and really think about the impact of therapeutic selection on your patients from a big picture perspective. Thank you very much.
Thank you so much, Dr. Steen. And we had some questions roll in, so I'll go ahead and fire them at you. Have you used VEP and ERD testing for glaucoma monitoring? What are your thoughts on that technology?
I have not used VEP or ERG for glaucoma detection or monitoring. There are so many tools that we have, and I think one of our biggest challenges is determining what is going to be most effective in our workflow. I feel that if I add one more piece, would it really change my management? I think about that every time I do any clinical or ancillary test. And if that result of any test is not going to change the way I manage the patient, I step back and really think about if that test is necessary. So again, an option to consider, but think about how it impacts patient management.
I think it's an excellent approach. This next question is any ocular side effects of nitric oxide taken by weightlifters or other reasons systemically? When would you advise against its intake?
That's a great question and not something that I have experienced. I do not have any weightlifting patients. I am not specifically familiar with a concern of overdose from a systemic perspective on ocular perfusion of nitric oxide. So thank you. There's something for me to dig into.
This next question is, can a disc hemorrhage be found in a patient whose glaucoma imaging or workup is completely normal aside from cupping?
Yes. So that's where we go back and we say, is this a true disc hemorrhage related to mechanical stress that is glaucoma? Or is this a disc hemorrhage that may be related to systemic perfusion or reduction in optic nerve perfusion? And how do you determine the difference? Well, measure blood pressure, measure pulse, talk about potential symptoms, Flammer syndrome, especially in your female thin patients. Ask about symptoms that could be associated, think about primary care involvement, and monitor the patient over time. Watch for any early change that could indicate development of glaucoma.
Excellent. This next question is, I have trouble determining if the OCT neurofibrillary scan is reliable or not. Do you have any tips?
It's one of our biggest challenges. And sometimes the answer is it is not reliable. So, first thing that I do is I go back to the anatomy. Is what I'm seeing on the OCT reflective of the patient's anatomy that's sitting in front of me? Second thing I do, if I'm not sure if they do correlate, is I re-image the patient first and foremost. See if that area or that anomaly is repeatable. Sometimes, you may monitor again on another day, but go back to the anatomy first.
Those are excellent tips. This next question is, if I have to lower the IOP, say from 30 to 15 or 12, and it's known that the episcleral venous pressure is 15, how, physiologically is the flow going to work?
So genuinely, if you feel that you know your target early on, which is challenging to do, but if you know that your target is 12 and they're at 30, and generally episcleral venous pressure is generally 7 to 10-ish. It's usually not that high unless there is a condition like carotid cavernous fistula that's elevating the episcleral venous pressure. I'm assuming we're talking primary open angle glaucoma. So generally, we can get to that 12-ish range with topical therapy, SLT alone, consideration of MIGS. If you feel that you need to go below episcleral venous pressure for any reason, that means that there needs to be true subconjunctival surgery, whether a Zen, gel stent, a trab, or a tube. We need to create a new outflow pathway that does not, again, have aqueous pass through the trabecular meshwork. That patient needs surgery to get below episcleral venous pressure.
And how significant is it in assessing horizontal CD ratio as compared to vertical CD ratio in glaucoma patients?
Again, I would argue assessment of the CD ratio goes to the bottom of your list. It's something we document, but really something to think about the habit of how you're assessing the health of the neuroretinal rim. Vertical matters most, but again, the whole context of what that patient's neuroretinal rim looks like is valuable.